here, I'm actually going to put it in the chat. A link to the DSM, that DSM-5 TR. It's a full copy of it. You will need that for our training. This is going to be a very participation heavy training. So please be prepared for that. There's going to be breakout rooms. There's going to be word clouds. There's going to be polls and questions and all those kinds of things. So just be prepared for that. As far as questions go, Gabby had said, put them in the chat, mic off and ask. As a reminder, as a reminder to leadership, please jump in and answer questions on my behalf. If you feel like they are, for one, if you feel like I'm floundering, don't just let me drown out here. But for two, if it is like more ViaQuest specific or maybe program specific, and please feel free to cut me off and answer those questions too. And then lastly, to remind everybody, there is a reason why we call what we do a practice and not a perfection. Okay, so like we are constantly growing and we are constantly taking trainings and learning and evolving. So I say all that to say that I know that there's a lot of us in the room, and I'm sure that there are like hundreds of years collectively here of practicing with diagnosing and everything. But just remember, it was only like 2 versions of the DSM ago that autism, Asperger's, and pervasive developmental disorder, not otherwise specified, was all 3 separate things. And now it's all autism, right? Not even just diagnosing, like if you were practicing before 2018 in Ohio, you might remember like Ohio's health home model and how everything got turned around with behavioral health redesign. And now all of a sudden we have TBS and PSR, and what are these things and how do they bill? So things are always changing and evolving. So our objectives today are to identify common barriers to clinical diagnosing and the impact of misdiagnosing, to review the importance of medical rule-out for conditions that present as mental health disorders, to increase clarity and understanding the difference between diagnoses with similar symptom presentations, and to discuss resources available to utilize for initial and updating diagnoses, including the interdisciplinary approach. So we're going to start off strong with a case study. So if we could get the case study Teresa put in the chat. I'm going to go ahead and read the case study, but I would like you to marinate on this for the rest of the training. I will reveal at the very end what Teresa's diagnosis is. So if you guys could come up with, by the end, a diagnosis for Teresa, and then if the NPs, if you guys could also come up with what would you be prescribing Teresa. So Teresa is a 50-year-old African-American female presented to the hospital with a history of bizarre delusions, hallucination, disorganized speech, and disorganized behavior. She's experiencing these symptoms for the past 1.5 months and was unable to tell the providers why she was in the psychiatric unit. She does not have depression, homicidal, or suicidal ideations. Her past medical history showed that she had previously had a history with acute myeloid leukemia, diabetes 2, epilepsy, HIV, and hypertension. During the physical exam, her vitals were good. She was asked about a scar on her right knee, and she said that it was due to a recent, it was a wound that occurred when homeless people had recently broke into one of her homes and attacked her, which, by the way, this was confirmed as a hallucination. She kept insisting that the scar was still bleeding, even though it had healed. The patient looked poorly groomed and unkempt. Upon examining her mental status, her behavior was childish, but she was also very cooperative. She could read and comprehend and repeat, as well as name things, and knew what day and time it was. She was unable to write a complete sentence, nor was she able to recognize a person or situation. Teresa was experiencing euphoria, but her affect was appropriate to the content. Her thought content included grandiose delusions and an overabundance of thought, while her thought process consisted of loosening associations, talking quickly and erratically, and unable to keep on topic. During the initial presentation, Teresa was hysterical and showed aggression when she was not believed. She would share extreme delusions that she was a child celebrity and also believed that she was the daughter of the US president. She would remove her clothing in public, talking quickly and erratically, jumping rapidly between ideas, engaged in movements that served no purpose, as well as an extreme need to share her ideas. These symptoms were also observed by the nursing home that she resided in prior to her admission to the psych unit. The hallucinations, delusions, disorganized speech, and grossly disorganized behavior were present for 2 weeks in the absence of her mood symptoms. All right, so again, we will go over at the end. I will reveal what Teresa's diagnosis is and what this provider prescribed for Teresa, and we'll see how things kind of land. So as a reminder, with doing any kind of case study, do not read what is not there, okay? All of life is a whole big, it depends. I get that. However, this is the information that we have available to us for Teresa. Okay. So first, let's talk about some barriers. And we're going to start with the barriers that our clients face when just accessing treatment. So it takes roughly about 11 years for people to seek mental health treatment. Some of that comes from the stigma around it. Some of that comes from people feeling like they're not sick enough, like, oh, I have it bad, but like other people have it worse kind of thing. There's also the cost associated with it and really the accessibility. And that's because of those long wait times. Like 56% of psychologists reported that they have no openings for new patients and have long waiting lists. 26% of patients wait 2 or more months for care. Even taking a look at outside of mental health and looking at other kinds of providers here, this graph here is shows the average third next available appointment. That is a metric that was created that measures how soon patients can get in to see a provider. And this one is for research specialties. So, but anyway, so third next available. So usually the first next available is like, it's a cancellation. After that, it's something usually along the lines of, well, can you do December 19th at 2:30? I absolutely cannot. I am presenting a CEU that day. There is no way for me to move that around. I can't do that one. So, okay, third next available. So people experience these extremely long wait times just to get in with a provider. Anytime I have seen a specialist, it has taken at least 3 months. And I will tell you this, like I am a walking statistic. Like I have not had a primary care physician and I can't even tell you how long. I finally decided to get one a couple months ago because I had an ear infection and I had to go to urgent care. And so I had to pay out the wazoo for that. And so I called one that was within my area. It's a ProMedica doctor because I don't want to have to do the whole, linking my Epic My charts. And so the next available that I could get in with this primary care physician that was closest to me, and it was a ProMedica in the ProMedica network, was in April. So that's my first appointment that I called for back in November, is in April. So our clients are experiencing now. Could I go and look out for somewhere else that can get me in sooner that I'm going to have to drive? Yes, absolutely, I could. But I have the privilege of being able to do that. Some people do not have that privilege. Some people have to deal with who's within their network, who's within walking distance. Is there a bus route for that provider? So all that to say is that there's barriers to just even accessing treatment. So I would like to know, though, what are some of the barriers and challenges that you encounter when you are trying to determine a client's diagnosis? So one of two ways here: either pop out your phone and you can scan the QR code, or you can go to slido.com and enter the code 525525. And I'd like you to tell me what are the barriers and the challenges that you encounter on the day-to-day when determining a client's diagnosis. Yeah. All right. We've got some coming in. This is really cool. I'm actually piloting this like Slido deal here. Um, so it's really cool kind of how to see it like play out. Hopefully it has the capacity for the amount of participants that we have. All right. Family history, poor historian. So poor historian keeps getting put in. That's why it keeps coming up like bigger and in a different color. And then the other one that keeps coming in, it looks here is like collateral info, lack of info. Again, poor historian. When staff aren't forthcoming about symptoms they are seeing from the client, nonverbal awareness, mistrust, having to diagnose after just one session. These are great, guys. I'm going to give it like 30 more seconds here. Mistrust is another one. Okay. These are all excellent answers. So some of those that a lot of these were on there as well. But let's talk about some of these that maybe weren't. So one of the barriers to diagnosing being lack of training that you may have had. Now, personally, with a master's and a bachelor's in social work, I had like my interviewing class in undergrad. I had like a mental health class in undergrad. And then I had like an 8 week quick summer class on the DSM. And that was it. That's all I had. So my experience with diagnosing really came from on the job training. And I was very fortunate that I had an amazing supervisor that actually took the time to understand how I learned and worked through things with me in supervision to make sure that I was looking at the big picture kinds of things. Time restriction was one that I definitely saw on there, right? Like you have at most to bill for it, like what, 45 to 60 minutes, maybe. Um, you have to, and in that time, you've got to do a biopsychosocial assessment. You've got to conduct the diagnostic interview. You have to build rapport, right? You got to trust people. You got to like get these people to trust you enough to tell you their deepest, darkest things that have been going on. But not only that, we just talked about how long it takes people to get in to be seen. And they're finally here. The appointment day is finally here. They are ready to like unload these things that they have had going on. And you're asking questions like, and what's your family history? And do you have any history of that? And you have all of these like robotic questions that we have to ask because we have to include them, but it is not really, it's not why the client's there. And so that can be discouraging too, because they really just want to talk about this recent thing that's going on, but we need the big picture. So we have to ask these other kinds of questions too. Poor historians is one I definitely saw. Defensiveness. Maybe these clients are slow to warm, they're shy, maybe they're very verbose. And what's their motivation for seeking treatment? Are they trying to get prescribed a certain kind of medication? Or are they looking for something to support getting a disability check? Do they have any kind of like unmet need going on? Maybe they have a roommate who has a ViaQuest person come in and meet with them a few times a week. And so for them, it looks like, oh, well, you get a visitor. I would like somebody to visit with me. I'm feeling lonely. So what's their motivation for coming in and or for getting symptoms in the first place? Or I'm sorry, getting treatment in the first place. And then also, we've got this battle between the DSM and the ICD-10. So the DSM, this is what we're trained on because this is what we use to guide our treatment based on the symptom presentation, which is great. But in order to bill it, it has to be translated into an ICD-10 code. And the problem with that comes into place is that those don't always line up with one another, right? So, like as an example, like the DSM classifies dementia as a neurocognitive disorder, and the ICD-10 does not. So there is some stuff that gets lost here in this game of telephone sometimes between what we're diagnosing via the ICE or via the DSM, and how we have to bill it out to insurance via the ICD-10 code it gets. Okay, I'd like to do a little exercise with you guys. Just quickly put in the chat your answer. And of course, we got to do this is that. Can you guys hear that okay?
No, you'll have to reshare for
Okay.
sound.
There we go.
Count how many times the players wearing white pass the basketball. How many passes did you count?
Okay, how many passes did you count? Quickly in the chat. I'm like looking at my iPad over here too, so that I can see everybody. Good, good. Okay.
The correct answer is 15 passes. But did you see the gorilla?
How many of you guys saw the gorilla? Oh, okay. All right, we got a couple no's. Perfect. That meets that serves the purpose of why I'm doing this. Okay.
This video is
Perfect. Can I have Gabby or Kim, can you guys clear the annotation on the screen for me, please? Um, okay, so the point of showing this is that sometimes we are our own barriers to diagnosing clients. Sometimes for those of you, and I'm glad that there were some, you guys were so focused on the white shirts because that's what you were told to look for that you completely missed somebody in a gorilla suit walk through the middle of the group. So I think of that, I see this and I think of things like reading a client's chart before seeing them. And so if in that chart it says in there that they have a history of, let's say, bipolar disorder, you may go into that interview with them and be blinded, or I'm not sorry, not blinded, but you're wearing bipolar glasses now. Okay. So everything that you're looking at is in the lens of, does this meet bipolar disorder? And when doing that, you may miss the gorillas of other things that are walking through this conversation that you're having. And the reason that that's so important is because not only do we want to get clients in and be seen, because we do. Clients have been waiting a long time. It has taken courage for them to be able to come and see us, right? So we want to get them in and seen, and we want to get them in and seen at like the lowest level of care. But at the same time, it is important that we have a comprehensive diagnosis because this is how it guides treatment, right? So, as an example, like PTSD is commonly misdiagnosed as ADHD. Well, if you're working with ADHD, that's going to be working on executive functioning skills. If it's PTSD, you're going to be working on things like regulation and narrative type therapies, right? In the medical sense, if the client is bipolar and is misdiagnosed as having depression and you only prescribe an antidepressant, you could send them into a manic episode because they also need a mood stabilizer with that. So there's that. There's the future providers that come through and who are going to take care of treatment after you. But then there's also our TBS staff that we have. And this is really important because I'm a very big advocate and of the stance of like staying in our lane, staying within your own scope of practice and everything. But we as licensed staff have an obligation to our TBS staff who may not have the same kind of experience or education that we do, that know to read in between the lines and ask different kinds of questions, to be able to identify like what's going on. They are relying on us to do that. Now, I would like to show you an example because I don't know if I know that I teach it when I am doing the new hire training up here in Northwest. One of the things that I will or that we tell over and over to the TBS is you have to read the psych eval. You have to, or the diagnostic assessment. You have to read that. That's where you're going to pull X, Y, and Z information from so you can know how to be working with this client. Okay. So I'd like to show you an example of a psych eval that like our TBS would be using to their treatment. Okay. So I did go through and I blacked out any identifiable information, not only of the client, but of the practitioner. And I would like to go over this with you from the lens of a TBS staff and what they would be seeing to try to help develop their treatment plan. Okay. So I went through and I highlighted the information that they would want to look at and pull out. The first thing here, this biggest heading that we get here is this personal history of other mental and behavioral disorders. It also says here like personal history of healed or other physical history or trauma. And then it says dementia. Now, reminder, like TBS don't work with dementia. So that would not be like something that TBS would be addressing. So let's go through and see here. So first we've got some mental status-y type information. Person denies anxiety or depression, denies any suicidal ideation, substance abuse, no hospitalizations, no auditory or visual hallucinations. So I come down here. Where do they gather any other information? It says AL staff and chart. I'm going to go on a limb and say that that means assisted living staff and chart. Coming down, okay, denies abuse or trauma, or substance abuse history. And now looking at the psych review or the review of the psychiatric symptoms, there is nothing in here that indicates any report of depression, anxiety, mania, excuse me, no other psych concerns, but it says aside from what is noted above. But if I go and I look at what, like this is what was noted above, the only thing that it's really telling me is this personal history of other mental and behavioral disorder. Mind you, I'm looking at this as a TBS staff. So I'm going to come down. They missed the strengths and barriers. Looking at the mental status exam. Okay, we've got poor concentration. We've got disoriented to time. Their their immediate memory was impaired. BIM score of 8. And then looking at here for their problems, right? This is like really the big part where we tell TBS to go to for when doing their treatment plans, right? So problems, it says dementia is our first problem. Cognitive decline, some forgetfulness, but TBS don't work with that. Coming down here, it says personal history of other mental and behavioral disorders. So it does say diagnosis present per chart, but the patient denies and did not exhibit any concerns during the exam. So looking down more, data reviewed, it did say up above that they looked at the chart, but there's like no other elaboratory information about like what was viewed in the chart or the other staff that they talked to. So coming down here, let's see the plan here. It says that they are being referred or that they meet medical necessity for TBS and mental health nursing. Let's see, this one is just mental health nursing up here. So TBS and mental health nursing for the diagnosis of dementia, personal history of healed other physical trauma, and then personal history of other mental and behavioral disorders. So it doesn't meet medical necessity though. There's nothing in there that indicates this is what either we saw in the chart or heard from the staff or that the client told us themselves. And so I come down here, let's see, we're gonna, if they continue to meet, we're gonna follow up. Didn't do any counseling activities, aims here. Okay. Diagnosis. They were diagnosed with adjustment disorder, unspecified, and then in unspecified dementia and behavioral disorder. Those were their two F codes. So it's an adjustment disorder, but I have no idea what this identifiable stressor is that supposedly had occurred, because that's how you have an adjustment disorder, right? An identifiable stressor. So there's nothing in there on that. And then that personal history of other mental and behavioral disorders, that's a Z code. So that's not something that we could diagnose on its own anyway. That is an life event type thing. And then they are referring for TBS services due to, again, that physical history and trauma, personal history of other mental and behavioral disorders, and dementia. And so it does not say on here, and I'll double check myself just to be sure, it does not say on here that they were prescribed any psychiatric medication. But let's say, for example, that they were prescribed, they were already on medication. Okay. And so you might be saying, but Lauren, if they're on medication, then and they're not reporting any symptoms, that means the medication is working, right? That's what we want to do. And you are absolutely right. That is the point of medication management, to dilute the symptoms so that they are not impairing functioning 100%. If that was the case, though, in that assessment, I would hope to see what is their history of symptoms, to be teasing out the symptoms that you are currently seeing that is maybe being minimized and well managed on that medication. And so what is the history of those? What were those symptoms like prior to their management of, prior to them being on any medication? Okay. So let's talk about the medical aspect of mental health diagnosing. So it's important because we are systemically eliminating any of those potential physical causes for the patient symptoms. So making sure that this isn't being attributed to any underlying medical condition. We are looking for an accurate diagnosis so that we can get appropriate treatment. If we have appropriate treatment, this is going to avoid any unnecessary interventions. And so when I think of this, I think the easiest example, at least in my head, to conceptualize is encopresis and enuresis, right? So, and if you guys don't know me, I have like a really strong background in working with kids. But let's talk about, and so that's why like this one comes to mind easily for me. If a child is, or if a person, if a person is urinating on themselves, and I am trying to talk to them about like motivation system and readiness for change and all of those kinds of cognitive type things, but in actuality, they have like something medical going on, I'm setting them up for failure. I'm not being respectful of their well-being because they can't control this anyways, right? And for the therapists that are in the room, like one of the things at the very beginning of a diagnostic assessment asks about who is their doctor. So if I'm your patient and I say I don't have a primary care physician, then one of the things that maybe needs to be worked on with me is that I need help getting a doctor, so that way we can do some medical rule out things like a physical exam. Like when was the last time I had my lab tests done? What are my vitals looking like? Do I have any hormone imbalances or vitamin deficiencies? Perhaps I need some imaging studies like an MRI or a CT scan to see if I've got any structural abnormalities in the brain, and then getting a really good detailed medical history so that we can see any causes or anything that has been building long term. Okay. So I would like to launch a little quizzy-do here. I've got 3 categories here. The first one is has multiple sclerosis, stroke, and traumatic brain injury. The second one is thyroid disorder, diabetes, vitamin deficiency, dementia, Parkinson's, and anemia. And then the last one is stomach and digestive issues, heart conditions, and lung conditions. So if we could go ahead and launch the quiz, and you guys tell me what group of medical conditions could easily be confused for each of these different, these cluster of conditions. So I'm sorry, what mental health condition could be easily confused for this cluster of medical conditions? So I'll have you guys go ahead and do that.
Okay, I just want to say I cannot navigate this on my phone. Can you hear me?
Yep, I can hear you.
Okay. So, like if I go to the test and scroll back to the three, or I can't get back to the other.
Okay.
So
You know,
I can't answer it.
it's totally fine if you want to put it in the chat. That's fine.
I'm on my
I don't
phone
plan on
too.
like 100% participation anyways, just because of the size of the group that we have. So,
Well,
yeah,
I just
I'm
don't
on,
want you to think that I wouldn't, because I
nope.
would, but
I'm on my
I'm
phone
just,
also, but I let Gabby know. And the same thing, I couldn't scroll back, so I just randomly tried to memorize it, I guess. The best after you reviewed it. I'm like, oh crap. I didn't know we were going by color. I'm like, so it is what it
Sorry.
is. But I'm
that's what I did too.
I'm having technical difficulties on my end. My computer won't let me join.
Okay.
Mhm.
Okay. I'm going to give it like 30 more seconds.
What is under the green section? I can't remember because right now I can only see the quiz and the
Sure.
first two.
Stomach and digestive issues, heart conditions, and lung conditions.
All right, thank you.
Yep. Anybody else need me to repeat? Okay. I think that looks good. It looks like the responses are starting to slow down a little bit. Let's see. I'll wait for it to get to 80 people. 78. No. Okay. We'll end it. So, going to share the results here. The first category is bipolar, multiple sclerosis, stroke, and traumatic brain injury. The orange category is depression. And then the last category there with the stomach issues and the heart conditions and the lung conditions is anxiety disorders. Just a little kind of interactive, check your knowledge kind of activity there. So I'm not going to spend like a ton of time on this. I just wanted to point out the sheer mass of things that can cause psychosis and psychotic symptoms. Okay, so it could be, and I think the one that like really wowed me, like when I was in grad school, was the urinary tract infection, presenting with like delirium. So, yeah, a lot of different things can cause psychosis in clients, and so this is why it's really important that we are doing a medical rule out and that we are crossing our I's and dotting our T's and all those kinds of things. Yes, I said it wrong. When we see something like psychosis, so that clients are getting accurate treatment. And now, after you have ruled out all of the medical type things, then we can treat this from a behavioral standpoint, right? So when I am looking at symptoms from this behavioral lens, I am always checking for frequency, intensity, and duration. I want to know how much, how long, how often, and since when, because most of those diagnoses in the DSM are asking about how long has it been going on. And not only that, but this is helpful to look back on when you are doing an update or when you're doing a treatment plan update to see how things have changed. So let me give you an example of how I would write up like a frequency, intensity, and duration for like a behavior. Okay, so you can take this as either a child or you can take this as like an adult with DD. So client's guardian reports that her outbursts and meltdowns, I put those in quotes because that's how the client categorizes them. If they would have said tantrum, I would have put tantrum in quotes. And that's because how I classify a tantrum, the next person come in might say, that's not a tantrum. Let me tell you what a tantrum is. Okay. But anyway, these outbursts or these meltdown, they present as crying, screaming, profanity, throwing items, her own and others, because I want to know, like, does she stop enough to think like, I'm going to bypass my own things? I don't want to break my own things, right? Kicking the wall or inanimate objects, as well as hitting and biting staff. This occurs 3 to 5 times a week and can last up to 90 minutes. Guardian reports client has presented with this behavior for, quote, several years, but it became what DSPs describe as unmanageable when her attendance at day program decreased from 4 days down to 2 days. DSPs have attempted to, quote, keep her busy by planning alternative activities, but this isn't always financially feasible. Clients' behaviors have gotten to the point where her guardian has been called to come over to the house to try to help de-escalate her. So when I go to do my DA update or my treatment plan update, and maybe I've got somebody, like a guardian or a DSP or a long-term care staff even, when I ask about it, they might be just so desensitized to what's going on. They're just like, well, this is just who they are. Or they're so overwhelmed. They're like, it's all the time. So even if they are presenting that way, I will just let them know. I just want to put some numbers around it so that we can check in a little bit and determine if things are getting better or worse. Because if things are staying the same, then obviously what I am doing or the meds it's not working. So getting these kinds of details really helps support the diagnosis, and then it helps us with keeping track of progress. Now let's look at one that might be used as like for an adult. So client reports, quote, trouble getting to sleep, which occurs every night. He states he goes to bed around 10 p.m. and it can take him up to 2 hours to fall asleep. He reports during that time he struggles, quote, getting my brain to shut down, which this writer clarified to mean experiencing racing thoughts that are not distressing in nature. So to me, that means not distressing in nature. He's not like, am I going to die? Are we going to be able to make our mortgage? This is more like, what am I going to get my mom for Christmas? And, oh yeah, I got that show that I like is on tomorrow. So it's been going on for as long as he can remember. He typically wakes up 1 to 2 times throughout the night, takes him about 10 minutes to fall back asleep. He also reports experiencing nightmares up to twice a week, but they don't cause him to wake from sleep and they don't present with any consistent theme. So this is just an example of how we would gather that how much, how often, how long, since when type information so that we can use it on our updates. And going into that, I asked Gabby back when I was asked to like put this training together to pull some demographics on ViaQuest clients off of SmartCare. And this is what she gave me. So as of October of this year, these at the bottom here are the top 5 diagnosed conditions of our ViaQuest clients, with major depressive disorder leading the pack. So as we go through this training and as we talk about similarities in symptom presentation, I'm going to be focusing on those 5 categories because it's really surprising how much overlap comes with some of those. So just here with schizophrenia, bipolar, and major depression, it can be confusing which ones share the similar symptoms and how are we differentiating Y and Z. And back to all of them can have experienced psychosis, those hallucinations and delusions and the suicidality. But, depression doesn't display with deficits in executive functioning. So the first one here that we are going to look at is major depressive disorder. Now, if you're not familiar, if you've only ever had like the handbook version of the DSM or the desktop reference version of the DSM, in the full DSM, the Big Daddy DSM, it has like after each of the diagnosis, it has like what is the cultural things, what's the prevalence, all this, and then it'll list for you all of the differential diagnoses. So these are those differentials that are listed in the DSM for major depressive disorder. And so as we go through these, I am going to pull out one of them that I feel like either gets lost or forgotten about or misunderstood for us to elaborate on. And for major depressive disorder, that one is going to be disruptive mood dysregulation disorder. And how this one, and I admittedly, when I was starting out, very often mixed this up with intermittent explosive disorder. So what I would like you guys to do in the frame of frequency, intensity, and duration, can you guys tell me, looking through your DSM, or if you know it off the top of your head, that's fine too. What are the differences in frequency, intensity, and duration for disruptive mood dysregulation disorder and intermittent explosive disorder? Both of them have these verbal and behavioral outbursts that are out of proportion to the event. But how do they look different? There's a couple other things that are different between them too. So if you know those ones as well, you can include those ones in the chat. So you can do it in the chat, you can mic off, whatever's easiest for you. I always like the mic off feature. I think it's just faster that way. Okay. So one of the things I see in the chat is anger, but both of them have, so anger for which one? Like I said, you guys can also just mic off too. Yes. So DMDD, multiple outbursts daily. DMDD has persistently irritable mood in between outbursts almost daily. IED comes out of nowhere. DMDD must last at least a year, the max pause of symptoms of 3 months. IED is episodic. DMDD is consistent. More persistent mood dysregulation than intermittent issues separated by calm. You guys are good. So, let's see. The amount of time spent unregulated is 50% of the time in IED. IDD aggression is out of proportion. Well, both of these are out of proportion. So let me show you what this looks like. So for disruptive mood dysregulation disorder, it has to be at least 3 per week. Does not have to have destruction to property, but it can. And this has to be going on for 12 months. Age of onset, not before 6, not after 18, symptoms present before 10. And then the mood between outbursts, this is a really big one, is that it is persistently angry and irritable. Now, intermittent explosive disorder, 2 ways to meet that criteria. We can either have 2 a week, if there is no destruction to property or assault, and it has to be going on for 3 months, or 3 just total with destruction to property and or assault within 12 months. Age of onset for intermittent explosive disorder has to have a chronicle age of at least 6 years old or equivalent to their developmental level. And then between outbursts, they are relatively calm without persistent anger. Another big thing too with intermittent explosive disorder, it has to do with motivation. There shouldn't be any premeditated with that. So, and it's not to achieve some kind of tangible object. So this one I always got confused on because to me, this is just verbal and behavioral outbursts. And so you really have to dig down deep and figure out how long, how much, how often, to what extent, right? Are they breaking things? Are they hurting people? Okay. So I'm now going to introduce you to Nico. So if we could put the PDF of Nico in the chat. Now, this is your like fourth assessment or eval of the day. You've got 3 to go. So we need to kind of come up, we got to get our notes done. So I would like you to go with what is your gut reaction. I mean, check it out in your DSM to check yourself, but this is not like a CEU day where we can sit here and kind of take our time. We need to kind of get through these assessment eval. So that's the headspace I want to put you in. Okay. So Nico is a 17-year-old male high school student who has requested counseling services for himself to work through his concerns about his sexuality. His parents, wishing for him to be healthy no matter what, complied with his request and accompanied him. So Nico's been isolating himself from other males, and he spends the majority of his time socializing with females. He actually goes out of his way to being around other males, including teachers and the coworkers at his part-time job. He even quit the men's basketball team because it required him to be in such close contact with other males. Now, Nico identifies as heterosexual, but he constantly worries that he might be gay. He runs through scenarios that would provide him an opportunity for physical or sexual contact with other males. And then he checks in with himself to determine whether or not he would find that contact pleasurable or more pleasurable than what he would have with a female. He's even tried watching gay pornography online to determine whether or not he would be turned on and achieve orgasm. But because he does not, he views that as his confirmation that he is straight. So he harbors some guilt for rejecting his male friends, even his best friend in particular, he doesn't talk to anymore. And even the friend was like, Nico, what's going on? What did I do wrong? And Nico didn't know what to say, so he didn't say anything. So he mentions when he sees his former teammates walking together in the halls, like he feels wistful, but then he just justifies it like this had to be done. His parents are pretty progressive, so he told them about what's going on and how this is making him feel. And they asked him, like, well, are you gay? Because if you are, then that would be fine. And this distressed him. And he took that as their open stance is like, well, my parents must think I'm gay. So he's concerned about how he conveys himself to others at his affluent suburban high school. He wears clothing that purposely conveys a straight persona. He aims to speak in a manner that demonstrates a flat affect. He is a skilled writer, but he does not think that he should be participating in the literary magazine because that would be gay. So he's constantly assessing what he does and thinks and wears and feels against what that means he is gay or straight. So remember, we've got to come up with a diagnosis, and we have got to move on to our next one, right? So what is Nico's diagnosis? You can use the QR code. If you use the QR code, it's going to take you right to the question. If you if you go to slido.com, first you have to put in the 525, and then it's going to give you the option to answer the question. So I actually have this one hidden. If you look up here at the top right, it tells you how many people have entered in, also tells you how many people are typing. So what is Nico's diagnosis? I want to be mindful of time because last month I was not. So I want to make sure that we get to our breakout rooms today. I'm gonna wait for like 3 more people to respond. There we go. All right. So Nico is diagnosed with obsessive compulsive disorder is Nico's diagnosis. So I see a lot on here of gender dysphoria. I see some adjustment disorder. I see generalized anxiety disorder. I see no diagnosis, but Nico's diagnosis is obsessive compulsive disorder. So that is a differential for generalized anxiety disorder. And let's look into a little bit more about not just obsessive compulsive disorder, but how this one gets very easily confused with obsessive compulsive personality disorder. Okay, so obsessions, these are thoughts and images and ideas that are intrusive, uncontrollable, and bothersome because they are repeating in the person's mind over and over and over again. They can be occasional or they can be all the time. These can be external obsessions like contamination, objects, smells, or they can be internal obsessions. Now, these are doubts about one's sexual orientation or romantic partner or burning their house down. Okay. You have to ask yourself, are these thoughts intrusive in nature? And then these are the different types, obsession types. I'm not going to go into all like the specific obsession types. Then obsessions can trigger compulsions. So these are rules and rituals and steps to ease that anxiety that is coming from the obsession. So it's only short-term relief, and then they have to do it over again. It is difficult to keep themselves from doing it. It impairs functioning. And the compulsions or rituals are usually made up by the person, and they don't have to make sense even to them. They will even tell you this doesn't make sense. I don't know why I have to point my guitar pick to northwest, because if I don't, it's bad luck. Okay. In my long-term care training on obsessive compulsive disorder, I show this video of a guy from an A&E episode who thought El Caminos were bad luck. And so every time he sees an El Camino, he has to like wipe it off. And he will do this for hours. He has to wipe off the bad luck. And you will see his family getting like frustrated and irritated with him because he has to do this. And he keeps talking about it, the El Camino, and how much bad luck it is. And they're everywhere. So the purpose of the compulsion is it is either prevention seeking. So I want to stop something bad from happening, or this is reassurance seeking. I need to know that the bad thing didn't or will not happen. So it's important to know that it doesn't have to be ongoing, like the wiping off the El Camino. It doesn't have to be like that. Nico's were not 24/7, but as the things came up, they got to a point where they were distressing for him. It was impairing his life because he didn't want to engage in the activities that he wanted to, like the literary club. He didn't want to be on the basketball team. Well, he did want to, but he quit because he didn't want to be anyone to think that he was gay. So this often, especially in media does a horrible job making this uphill battle for us, distinguishing between obsessive compulsive disorder and excessive compulsive personality disorder. So in the personality disorder realm, this is a focus on perfectionism, orderliness, and control, whether that is interpersonal or mental, and it is at the expense of flexibility or efficiency or openness in a variety of contexts, right? So I go through and I list on here on the other side, like what are the examples, like from the DSM, but this could be something like, if you want it done right, you got to do it yourself, right? However, other tasks are neglected or deadlines and are missed because of these personal set standards that the person has that they made up for themselves, right? Holding on to items of no value to the point where maybe hoarding starts to occur. So focused on the itinerary that you've planned for your family trip that you miss things that other people wanted to do, or the trip just becomes no fun at all because you have such a hold and it has to be done this way. I noticed that I don't want to say I was like developing like obsessive compulsive personality disorder. That's not what I mean to say. But I would even notice with myself, I would get like I'm a crafter, so I like to do like crafty things. So I would get like so hyper focused on things like this is not straight. I forgot this. It doesn't line up the way I wanted it to, that I would have to start telling myself, like, I'm going to choose to be okay with that. That is my choice. And I'm choosing to be okay with that because it is very easy to get into this like tunnel vision of like, no, it has to be done this way. It has to be done this way. But I wouldn't let that, stop me. I wouldn't like stay up all night and miss sleep at like fixing this craft project. So let's talk about then like how we differentiate between them. So the first thing is the core driver. So when OCD, they need to ease the anxiety from the obsessions that result in compulsive behaviors to mitigate the intrusive thoughts. So obsessions create anxiety, and to ease the anxiety triggers the compulsive behaviors. In obsessive compulsive personality, the core driver is that this is a sophisticated defense structure within a personality designed to protect against the discomfort of any perceived flaws or inadequacies. All right, in OCD, this is ego dystonic. So the actions and thoughts feel alien to them, and they recognize this as irrational. It amplifies their anxiety and distress because they know that this is irrational. But in obsessive compulsive personality disorder, this is egosyntonic. So the behaviors are in harmony with the individual's perception and their values. So they view this as rational, that it needing to go a certain way and look a certain way to the point where the intention of it was lost, that absolutely is rational. So Slido only allows me to do like so many free word cloud thingies. So this time we're just gonna have to put it in the chat. So what are some of these similarities then of obsessive compulsive disorder and obsessive compulsive personality disorder that cause people to get them mixed up with each other? And you can look through the DSM if you want. You can also just rattle these off the top of your head, either mic off or put in the chat. Routines, consistent behaviors to comfort, routines, repetitiveness, anxiety, increased behaviors, have a strict routines or rituals, thoughts and behaviors cause distress, rigidity, anxiety, preoccupation and worry, need for control, out of alignment with norms, anxiety, obsessions, and routine. So according to the DSM, the similarities, there's risk avoidance, there's the obsessional tendencies. Definitely we said in the chat too, that the behavior patterns can cause distress, just difficulty tolerating uncertainty and anxiety, and like I said, the media really works against us, and pop culture with like, oh, it's OCD, because I have to have it a certain way. That's not OCD, and that's probably not even OCPD, probably just attention seeking. But anyway, that is obsessive compulsive disorder and obsessive compulsive personality disorder. So then moving on to the bipolar disorders, a little reference to the stat here, 1,976 people of our clients diagnosed with bipolar disorder. So looking at bipolar disorders 1 and 2, here is the list of the differentials for bipolar disorders 1 and 2. And the one out of here that I would like to draw attention to is cyclothymic disorder. Now, I am a very visual learner. I hope that you guys are too, because this is how I'm going to explain cyclothymic disorder. So this is a normal variation in mood. We've got ups and downs, from baseline, but nothing really dramatic and long term. Our bipolar disorder, we've got that mania for at least 7 days. Then we go in through a period of depression. And you only have to have one manic episode in your life in order to meet the criteria for bipolar 1. Bipolar 2, so hypomanic episodes, has to be at least 4 days. I think of this as mini mania. So this puts stress in your life, but it is not like to detriment. I think of this as like manic episode is not only did I spend all my money, but I've taken out credit card debt and I've pawned things, and I have put myself in the negatives. Hypomanic episode, I have spent the majority of my money. I've got 3 days till payday, and I'm relying on my speed and reward points for my meals. But I'm not going to put myself into debt over it. So that's kind of how I kind of conceptualize the difference between the two. And then there's cyclothymia. This is not quite bipolar 2, right? It has to have a 2 years without a gap of 2 months in between. So here we go back to frequency, intensity, and duration. How much, how often, how long, since when? So they have hypomanic and depressive symptoms, but they do not meet that full criteria for either of them. And so this is commonly seen in men with gambling problems or compulsive sexuality. Can also be seen in women with compulsive buying and binge eating behaviors. So I will admit cyclothymic disorder is one that I always forgot about when I was doing diagnosing. So with talking about bipolar disorders, though, we cannot talk about bipolar disorders without an honorable mention of borderline personality disorders. So these are how borderline and bipolar are similar: the identity disturbance, the affective instability, suicidality, all of those things. You tell me, how are they different? What is the different factor? How are they different? I don't know why I'm continuing to try and say differently. How are they different? In the chat or mic off. Yeah, make sure you tell me in there too which one you're referring to. Brief mood swings, but rapidly changes. Borderline, attention seeking, medications don't help. Bipolar symptoms are episodic with no situational triggers. Borderline, fear of abandonment, absolutely. Fear of abandonment, all or nothing thinking, manipulation and control. Trauma, borderline, more issues with relationships. Bipolar, sleep disturbances, borderline symptoms are always present. I'm sorry, yeah, bipolar symptoms are episodic. Okay, excellent, guys. So absolutely, you guys are nailing it. You guys are killing it this training. So symptoms for borderline are triggered by life events. For bipolar, it's neurochemistry. That affective instability, borderline is patterns. Bipolar is symptoms. Borderline is, okay, it can be multiple times a day of that affective instability. Their mood changes, short lasting but rapid in borderline, and extreme but stable mood changes in bipolar disorder. And then one of the things that I saw actually a few times in the chat was how borderline personality disorder can be triggered by trauma. And absolutely right. So this is another one that can easily be misdiagnosed. And not just talking about PTSD, where it might be one significant event. What we don't talk about and what there's not enough training on is complex trauma. And so checking for trauma should be as a routine part of an intake on a client as vitals and just anything else. It it affects so much. So let's talk a little bit though more about like that complex trauma, that interpersonal that occurred repeatedly over a long period of time. And you're not going to know this unless you take the time to get that detailed history about themselves. And so complex trauma refers to a series of events. In research, it's not uncommon, or I'm sorry, in research studies and like treatment settings, like it's not uncommon for people to be assigned as many as 8 comorbid psychiatric diagnoses in an attempt to account for that array of effects and survival adaptations that a person goes through who have been impacted by complex trauma. This is fight or flight. Yeah, people are afraid to be abandoned because maybe they've been abandoned a whole awful lot in their life. And that is how they view the world, is one big abandonment. So for presentation, this can have all of the symptoms that one would see in PTSD, but in addition, they have that distorted sense of self, difficulty controlling their emotions, challenges with relationships, and such as like anxious, avoidant, and disorganized attachment styles. Now, what's kind of interesting, I mean, interesting if you're nerdy like me, the APA and the DSM does not recognize CPST as a diagnosis like on its own. However, ICD-11, yes, there's an 11, even though we're still building on 10, there is an 11, that recognizes it as its own diagnosis. So I have hope that someday, if we all wish upon a star hard enough, that our DSM will include CPTSD as well. So when we think though about, it's not just one event that causes CPTSD. It is multiple events. So we're going to want to ask about things like parentification. Did they have to grow up too fast? Did they have to look after siblings? Did they have or excessively, right? Did they have responsibilities that were not age appropriate? Were they living with somebody who had severe persistent mental illness? Did they have a parent maybe with schizophrenia who did not have their symptoms well managed? Or somebody who was an alcoholic? Were they being pulled into adult arguments? Did they feel responsible for their parents' feelings? Other things too, like emotional neglect. I don't think people realize like how much emotional neglect like really can affect you. And I think people want to justify this and say like, well, they were doing the best they could and other people had it worse. And you're absolutely right. More often than not, people are doing the best they can with what they have in that moment, but things still happen and things still slip under the wayside. So when I think of something like emotional neglect, so, maybe they have a sibling that has like some severe behavioral or medical issues, and that sibling always gets a lot of the attention because they need it. They've got things going on. But because they're spending so much time with that, this other sibling, your client, may have some stuff going on, but because it's not as bad, it doesn't get priority. Okay. And so they have to sit with their thing for longer, untreated, and they have to feel like, they don't matter. Also thinking back, like if if we could go back in time and I could diagnose my brother as a child, he would most definitely be autism spectrum disorder. And so he had a lot of like severe behaviors growing up. Now, this was all the time. This was just part of the day to day. But as someone who's 4 years younger, that was scary at times, right? And so then there's my mom trying to have to mitigate that and manage that. And then there's 4 years younger me who's like, oh my God, what's going on? And so, I mean, things happen. This is just life, right? But that doesn't mean that it didn't affect us. Okay. The schizophrenia spectrum. So our stats here, 2,444 with schizophrenia, 2,518 with schizoaffective disorder. So here are the differentials for schizophrenia. Now, I am not going to be getting into things like positive and negative symptoms and all of those kinds of things. There is another training on schizophrenia coming up. So we're not going to talk about like first episode psychosis and all that kind of stuff. We're going to save that for that other training. That's going to be absolutely brilliant. I am just going to talk about differentiating between the personality disorders and the psychotic disorders. Okay. So the use of schiz in front of them all sometimes really trips people up. So someone with schizophrenia or the psychotic disorder, they experience hallucinations and delusions. Someone with personality disorder, the schizoid and the schizotypals, there are no hallucinations or delusions. Okay. So looking at schizoid, these people are uninterested in having any meaningful relationships. These people are usually loners. They might work part-time jobs. These are the kind of pop culture references. Hopefully you go through and you recognize at least somebody that you can identify with here. Batman, Squidward, the first episode of Dexter, according to Google. I've never seen Dexter, but these all meet the schizoid personality disorder type. The schizotypals, they have odd behaviors or beliefs that would catch others' attention that is not consistent with the rules of a given society. So they dress kind of odd. They've got weird vocalizations. It's hard for them to hold steady employment. I can remember seeing a friend of mine's like younger sister was walking home from work. I was like driving down the street and she was walking home from work and she was an odd duck. But she was like walking backwards in holding an umbrella and like I knew the route. Like I want to know how long, but she was walking backwards on her way home. And so I'm not saying that person, like, I'm not saying she has schizotypal, but I just always thought like, that is just odd. That is what that sounds like. Now looking back, it sounds schizotypal. And because we're 2/3 of the way there, I'm also going to throw in paranoid personality disorder to round out cluster A. So this is not the type of paranoia that is a break from reality like you're going to see in schizophrenia. So this is not like aliens are monitoring my brain. Okay. In paranoid personality disorder, this looks more like everyone is out to get me. And they are like, my partner is always cheating on me. They are constantly looking for proof to back up their paranoia. These things that they're paranoid about could actually happen. They're just not happening. They're hypersensitive to the world, and they are always looking for a fight and seeing people's motives as negative. So those are our schizzy, paranoid personality disorders. Now for the psychotic disorders, we're going to look at this in the on a schizo timeline. Okay, so starting with brief psychotic disorder, these are schizophrenia symptoms that are less than a month. Okay, so this is all based on time. It is less than a month. Schizophreniform is more than 1 month, less than 6. So we can think of this as it is forming into full-blown schizophrenia. All right. And then schizophrenia is the symptoms have been present for 6 months or more. So that's the big difference here between the brief, the schizophreniform, and the schizophrenia. It all has to do with the time. Okay. So I'm going to ask that we put Barbara in the chat. And I'm going to give you I'm going to summarize this. I'm not going to read this because we're going to send you into a breakout room. So Barbara, she's 51 years old. She's in the hospital with her husband because of suicidal ideations. She claims it's for a mistake that she had made at her job. So she has been experiencing some depression for some time. She's losing weight. She's struggling with sleep. She saw her PCP a week prior and all was clear on like the medical front, but he noticed that she was, depressed. So he, made a psych referral. And so, mind you, now nobody's likely getting in with anybody within a week, but we did talk about that long wait time to get in with people, right? So that's the kind of rundown on Barbara. you guys go ahead and make sure you save that into the chat so that you can access it, or from the chat so that you can access it in the breakout rooms. And we're gonna say like 10 minutes. Let's do 10 minutes. And we'll see if how long that takes you guys. And maybe the next one will be shorter or longer, just depending. So
How many people you want in a breakout room?
doesn't matter. Surprise me.
Okay. All right, so just a reminder, everybody, please go ahead and download the items. Once you go in the breakout rooms, you won't see the chat here. So please go ahead and do that. You will be pushed to a breakout room, and you'll see a countdown when you have 60 seconds left, and you'll be pushed back into this big group room.
Hopefully we've got a little bit of interdiscipline mix going on. I think that'll be really interesting to kind of hear about some of that discussion. Make sure you guys nominate a spokesperson.
Yes, nominate a spokesperson. We'll have about 13 rooms. It's randomized. But just one quick note before we go in the breakout rooms, we do take attendance here. And so Kim has been asking people privately, especially people who came in on their phones, if you didn't put your full name there. If you could just respond to Kimberly Weitzman and let her know what your name is so we can have attendance there. So we'll see you guys here in about 10 minutes.
And tell me, what did you guys come up with for Barbara's diagnosis?
MDD with psychotic features.
Okay.
Yes.
What
I'll
else
go
we
next. It's kind of
And
fresh in my head.
We had the same for our group. Same thing for our group.
Okay.
Our group also had the same thing, major depression with psychotic features.
Same for our group, and in terms of the psychotic features, we're on the fence because did she make a mistake?
Yeah, that was our group too. Same thing. We couldn't really determine whether that was a real fear or because it did match up with her job title or what she did. So we, not reading into it too much. We were on the fence about the psychotic features.
The hardest thing about case studies is not reading into it too much. I think that's a good indication that you like what you do when you're like, but I want to know more.
Our group was talking about schizophreniform due to the, duration symptom timeline being like less than 6 months and like more than a month, and, not having a lot of medical, issues or history. And prior to this, like she was able to hold a job, relationships, etc.
Okay.
So our group said major depressive, but there wasn't enough to indicate like psychotic features and anything else.
Okay.
Harry and menopause was also thrown out there too.
Yes. The one thing they didn't check was her hormone levels. So
okay. That's a good point. I love that. Okay. Any other ones that want to chime in before I reveal? No? All right. That's my drum roll. It is major depressive disorder, single episode, moderate with psychotic features.
You're no longer sharing anymore, Lauren.
Oh, dang. That was so anticlimactic. Hold on.
That was funny.
Okay.
Okay.
Major depressive disorder with psychotic features, single episode, moderate. Okay, so that segues us into schizoaffective disorder. I think this, and talking about how this differentiates. So it is major depressive disorder with psychotic features. And I'm sorry, I gotta like move all my controls and stuff around so that I can see the things I want to see. All right. So when looking at schizoaffective disorder, we have to determine which is the primary diagnosis. So we have a primary and a secondary. Is the psychosis symptoms primary, or is the mood symptoms primary? So, and the way we determine this is whichever one exists for at least 2 weeks by itself is the primary disorder. All right. So if you have depression for 2 weeks with no psychosis, or I'm sorry, during a 2-week span, there's no psychosis, then it would be major depressive disorder with psychotic features. Now, let's say somebody has auditory hallucinations and delusions for like 3.5 weeks. During that time, that those are like the only symptoms reported. Then after that, there's like a 5-week stint of like staying up all night, contracting an STD from multiple partners, nonstop talking, all while still experiencing the psychotic symptoms. Now we're looking at schizoaffective bipolar type. So you can only have one. It is either schizoaffective disorder, depressed type, or major depressive disorder with psychotic features. It cannot be both. So then I've got a few little odds and endsy other things too to kind of cover with diagnosing and thing. The first one being adjustment disorder. Now, as a former child therapist, I saw adjustment disorder was like used all the time. So reminders though, with adjustment disorder, there is a max duration on adjustment disorder of 6 months. After 6 months, they need to be reevaluated, okay? Because after that, they are no longer adjusting. This is something else going on. It can be reinstated, but you need to identify what is the new stressor, okay? And then looking at these specifiers here, the specifier should be where you start at when you go to do the update. So if it was, adjustment disorder with disturbance of conduct, I'm gonna first start looking maybe at those conduct disorders after I kind of, interview and everything. I don't want to put conduct disorder type, not conduct disorder specifically, but impulse control, and other conduct disorder, like that family of diagnoses. So, yes, you need to do an update and it has to be within 3 months of that new stressor. The other one too, and so adjustment disorder, and then the other specified and unspecified. So we see these quite a bit with like when we look at TBSU notes and we're looking at like clients' diagnoses, these ones come up quite a bit too. So a few things to remember here with other specifieds and unspecified. I'm sorry, it should just say other specified, not other/unspecified. So other specified should be lots of symptoms, but not meaningful criteria for anything. And like indicating that, like, hey, they are indicating these symptoms, but I'm not able to gather enough information, or like not enough information was present to be able to verify this. An unspecified should be an entry diagnosis that you follow up with over time. So going back to that like adjustment disorder, one of the things on there is for the other specified is like adjustment. So it would be other specified trauma and stressor related disorder. And then you specify it as adjustment like disorder with delayed onset of symptoms that occur more than 3 months after the stressor. Or you can do other specified trauma and stressor related disorder, and then it's adjustment like disorders with prolonged duration of more than 6 months without prolonged duration of stressor. Okay. But it has to change then. I mean, like we can't just let it sit as an adjustment disorder. Also wanting to mention too, autism, ADHD, reactive attachment disorder, and IDD diagnoses. So these need psychological testing in order to be diagnosing on these. We can indicate these as a rule out, and I would encourage you to do so because this is your way of saying, here, back at this time, I started seeing symptoms that support it. So you're creating that paper trail, again, that comprehensiveness for future providers to look at too. Or you can put it on as a collateral diagnosis, but only if you have the documentation provided to you that supports that where they had that psychological testing done. And then lastly, the category of other focus or other conditions that may be a focus of clinical attention. So, AKA, these are our Z codes. These are life conditions that aren't diagnoses, but they still affect treatment. This is big picture stuff. If I come into you and I'm saying I'm really depressed, that's one thing you need to know. But if I say I'm also homeless, like that's something you want to know and want to indicate somewhere in my chart, and so that you like that's going to significantly impact how we do treatment, right? And then using that Z code to support the interactive complexity where you are going above and beyond. You are overcoming the barriers to any typical service delivery. This is not just needing an interpreter. This is not just because it's a psych eval. It's not just automatically interactively complex. It is not just because it was conducted in a nursing home. That does not automatically make it interactively complex if that's what the baseline is. Okay, so as an example, a patient might have a Z code that indicates like a complex family dynamic, and that contributes to their anxiety symptoms. So it would be interactive complexity would mean that the provider needs to actively address the family issues during sessions, during the encounters, potentially requiring additional time to manage family reactions and their input during encounters. And then a new up and coming thing that's being talked about is the social determinants of health. These are non-medical factors that influence health outcomes to bring us to promote us and bring us to a state of health equity, where every person has the opportunity to attain their highest level of health. So, for example, poverty highly correlated with poor health outcomes and a high risk of premature death. Why might that be? Born into poverty, there's a greater chance for experiencing trauma. Trauma increases blood pressure and all of the other XYZ ACEs things. Also, there could be the location of where you live. Maybe there's a food desert. So your food options are places like Dollar General. Those don't have many nutritional options for you. So now you have a poor diet that increases health conditions like diabetes. And then there could be difficulty accessing healthcare, right? Transportation, maybe high wait times because you do have a provider nearby, but like everybody's going to them because everybody needs somebody nearby. So and all just because at the roll of the dice, you were born into poverty. Okay. So a few resources for you. You guys are going to get the PDFs of the DSM-5 Handbook of Differential Diagnosis and the DSM-5 Made Easy. So if we could, at the very least, just put the Handbook of Differential Diagnoses in the chat now, because you guys are going to use it on another case study. So I wanted to show you guys, I am also logged on my iPad. Can you, Gabby or Kim, can you guys make my iPad a co-host, please?
Give me 2 seconds.
Yep. Okay. So we're going to start broadcast. Cool. Okay. So a really cool app that I came across when I was looking for resources for this training was Medscape. So if you guys don't know about Medscape, this is a free app. It is absolutely amazing. I wish I knew about it before. You can look up things like medications. You can look up things like conditions. So I am going to look at psychiatry, and I'm going to look at adults, and I'm going to look at binge eating disorder. Okay. Gives me an overview. What's it look like? What are the differentials? What medication? How do we treat it? How is it managed? For the sake of time, I'm not going to get into all of them. There's also things like calculators. It has different, like PHQ-9, GAD-7, those type of scales for different things. There is also interaction checker. Shout out to Cassie for meeting with me ahead of time and telling me to use Lexapro and Seroquel as an example. So that's what I did. And it says the view the interactions found. And it tells me a bunch of information that I don't fully understand, but I totally believe that you guys do, about what happens when a person is diagnosed Lexapro and Seroquel simultaneously. So there's lots of other things too, that go with that are on Medscape for that you guys can access. In the DSM-5 Made Easy, there is this, there's a chart at the very back of the medical disorders that can cause, that mask themselves as different mental health disorders, as well as classes and names for medication that can cause mental disorders. Okay, let me think here. I've got 12 minutes. Let's do it. We're just not going to do 10 minutes. Let's go back into breakout rooms. You guys are going, let's get the case study of Dan into the chat. Please download Dan as well. And I would like you to use your handbook of differentials to determine what is Dan's diagnosis. And we're going to do like 5 minutes. That's probably pushing it, but
Five minutes?
yeah.
Okay.
So using the handbook of differentials, what is Dan's diagnosis?
You should be pushed to your chat. I will also put it in the chat for the groups too. Great, everybody's back.
Okay, a couple things. We're going to double up on this, all right? I want to give you time to put in the chat. What did you guys end up diagnosing Dan with? Because I'm going to go back to it, but I want to give you guys time to put it in. I also would like you guys at this point to put in the chat, what are you diagnosing Teresa with from the beginning? And for our MPs, what are you prescribing Teresa? So I'm going to go over my little spiel about this, and then I'll go back to Dan, okay? So
I actually had a Dan in the past. It was the other way around. It was a female client who was obsessed with a male singer, but yeah, I've had one of those before.
I've seen that in a TBSU note as well. But thinking about doing our diagnosis updates, I just want to re-emphasize the point of the importance of that frequency, intensity, and duration, so that we can check in to see, has our treatment actually been improving? Do we have the numbers to support our treatment? And also importantly too, utilize the TBS staff that are working with your clients. One, I am teaching TBS how to do a prog nurse note, and I get to the point where I'm talking to them about homework, and clients should have homework in between encounters, and you also may have homework in between encounters. An example of that might be if you know a client just saw their nurse practitioner the week before, and now all of a sudden you're seeing a dramatic change in symptoms, your homework should then be to follow up with whoever their nurse practitioner is and let them know, hey, something I want you to be aware of, that since that medication change, she is now talking that she is suicidal. So please check in with them. They are going to be they are the boots on the ground. They see all the things, and they are such a valuable resource for figuring out what is going on with these clients when we go to do the diagnosis updates. Okay, let's see. We'll go back to Dan. Dan, all right, looking at I didn't get you on this one. Yes, Dan, delusional disorder, and I spelled your romantic crumb. Absolutely, yes, Dan is delusional disorder, romantic type. And then for Teresa, schizophreniform. Let's see. We've got medication management would include atypical antipsychotic and mood stabilizer. Let's call for okay. So Teresa is going to be schizoaffective disorder, bipolar type. She was treated with a combination of antipsychotic, I'm not going to try and say it, a mood stabilizer, and an antidepressant. So that is the end. We have about 2 minutes left. If please follow up with like your supervisor. I can hang out here too and ask any or try and answer any questions that you guys may have if you want to ask them now. I am continuously working on my time management skills for those of you that this is not your first training with me. I promise 2025, we're going to get this down. So
can I say one thing, Lauren, real quick? For my NPs, we psychiatric nurse practitioners can diagnose ADHD with the proper protocols. That's okay. However, in the LTC setting, we're not going to be doing a lot of this. So for my people in the offices and now OC Health, we're going to be seeing a lot more ADHD. And so we'll probably be developing a protocol on how we want to do it with the Vanderbilt and that kind of thing.
Perfect.
So, but great job. This is awesome.
Thank you so much, guys. I will hand it back over to Gabby.
All right. So just as a reminder, if you logged in a couple minutes late, in the beginning, I said that I will be emailing everybody all the handouts that were provided during this training, the PDFs of the slides, and then also the evaluation. So the evaluation does need to be filled out and sent back to me. We utilize that for future trainings on how you thought this training was, and then what additional future trainings do you want to see in the future. We are currently already making our schedule for 2025. So if it's something that you would like a future training on, please put that in the evaluation. For licensed people, we're able to provide CEs for therapists that are licensed as either counselors or social workers in the state of Ohio only. So you will need to send that evaluation, and then we will upload your CE to CE Broker. So please send them by next Friday. I know there's a holiday, so try to get that done as soon as possible, so we can get those completed for you, and so we can make our schedules for next year. As Lauren kind of did say, our next scheduled training is already scheduled. It is going to be schizophrenia in January 24th. That will be presented by Lydia and one of our NPs, Julie. So we look forward to that next year. Like Lauren said, we'll stay on for a couple minutes, but if you have to go, it'll be great for you to follow up with your supervisor. But thank you so much, everybody, for joining.